Good morning, everybody. Thank you for joining us. I think we're kind of getting close to the middle of the summer almost. It's coming fast. I hope everybody's having a good summertime. And thank you for everybody who's joining. As usual, just giving it a moment to give everybody time to jump in today. We have a great one planned for you today. And just a little bit as far as updates go. That being said, I'll turn over to Dr. Dunn for our first update, for our main update.
Good morning, everyone. Thank you, Dr. Ozdalga. I just wanted to make a plug for Leadership Education and Advancing Diversity, the wonderful program that was started by Drs. Yamane and Powell. It's now the 7th cohort of LEAD that will be coming up. The application cycle is now open. The deadline for applications is July 23rd, 2023. Just as a refresher, the LEAD program is the vision is to develop diverse, inclusive leaders who advance health equity. And the program is a 10-month-long longitudinal program for educational scholars who will be fellows and residents who will be mentored by educational mentors that consist of faculty and educational administrators. And the application for both of those is open now. We really encourage Department of Medicine folks to apply. It is a very rewarding program, and the hard work is culminated in a workshop that is created by the scholars with the mentor help at the Diversity and Inclusion Forum, which will take place in May of 2024 this year. I will be putting the link in the chat to apply, and I hope to see many of you participating this year. And with that, I will turn it back over to Dr. Ozdalga. Thank you.
Thank you, Dr. Dunn, as always. And as always, if there's any updates you'd like to see, please let me know. Or is anything in communications you want us to share, please reach out anytime. I want to just briefly mention next week's Grand Rounds on Zoom will be Dr. Tyler Johnson. Many of you may know that Dr. Johnson co-hosts a very popular podcast called thedoctorsart.com and explores a lot of aspects in medicine, from compassion, humanity to just so many different facets of it. He will be coming to talk to us about lessons learned from 65 hours discussing meaning in medicine. So please join us next week for that one. Well, that being said, I'm excited to introduce our main presenter today. Our presenter is Dr. Maja Artandi. Dr. Artandi is a full clinical professor of medicine in the Division of Primary Care Population Health at Stanford. She's a leader in primary care, spearheading novel methods of healthcare delivery and education. She offers an impressive clinical background, has received several educational awards, leadership awards, and so on. Her expertise lies in the development and implementation of medical curriculum, focused on the patient-physician interaction, emphasizing communication skills, physical examination skills, medical decision-making, all to support clinical practices. She's a past co-director for the primary care education for Stanford General Medicine Residency Program. She's also was a medical director at Stanford Crown Clinic. So she was one of the key people, and we highlighted this through our annual report, taking care of our COVID patients not admitted to the hospital. And she played so many roles throughout the pandemic, including helping create how you do the physical exam on Zoom or in a video visit. She's currently the medical director of the Express Care Clinic here at Stanford. She's the past president of the Society of General Internal Medicine. She's a fellow for the Royal College of Physicians via Edinburgh. She's a co-president currently for the Society of Bedside Medicine, which I'm a member of, and she does amazing work there. I can attest to that. She's won many awards, Internal Medicine Faculty of the Year Award, for example, in 2020. Dr. Artandi is a dedicated primary care physician educator and mentor for many students, residents, and colleagues. And I just want to say I've known her personally, professionally since I started residency, my first year, perhaps how many years ago now? 16 years ago. She was initially my clinic advisor when I first came to Stanford the very first year. I've got the opportunity to work with her so closely through our bedside medicine program and Society of Bedside Medicine. She's an amazing clinician, amazing colleague, and definitely an amazing friend. I'm so happy to have the opportunity to introduce her today. She'll be presenting on improving bedside skills through targeted feedback. She's given this grand rounds elsewhere, including recently at Johns Hopkins. It got great reviews. So we're really lucky to have her with us today. Dr. Artandi, thank you so much for being here today. I will turn it over to you.
Thank you so much for the nice introduction, Arrow. And thank you so much for inviting me. I am more than honored to be there. Let me share my slides. Oops, one sec. All right. I have been a part of the Stanford 25 expert group on physical examination for many years. 8 years ago, we held the first Stanford 25 Skills Symposium and realized that there's a real hunger for mastering teaching bedside medicine skills. During that symposium, like-minded colleagues from all over the United States and from the UK came together, and we then founded the Society of Bedside Medicine. The society is dedicated to bedside teaching and improving physical examination and diagnostic skills. Actually, many of the members of the Stanford 25 group are also board members of the Society of Bedside Medicine, and we all share the same excitement for teaching bedside medicine skills. Today, I'm going to talk to you about improving bedside skills through targeted feedback. I'm really passionate about physical examination skills and how to help learners improve these skills. And thus I became very interested in the best way on how to give feedback, because we actually cannot improve without feedback. I have no financial disclosures. And here you can see an outline of my presentation. We're going to talk about the current state of the physical exam, then about the consequences of not being at the bedside, challenges and tips on how to give feedback. I'll talk about models to evaluate physical exam skills, and then I'll introduce a new model that we developed in the Society of Bedside Medicine, the 10-minute moment. So hopefully by the conclusion of this talk, you will be able to describe the importance of physical exam skills in the 21st century, recall challenges to and tips for giving feedback to your learners, and describe a novel approach to giving feedback on physical examination skills. Let's get started. And to get started, let's get back in history. Let's talk a little bit about the evolution of the modern physical exam, because the modern physical exam, as we know it, is really not that old. About 400 years ago, when you were a commoner and you felt sick, you went to a barber surgeon. That person would bleed you, pull out your teeth, maybe amputate a limb, and while at it, cut your hair. The birth of the modern physical exam started with Leopold Auenbrugger. Auenbrugger was the son of an Austrian innkeeper. And when he was growing up, his job was to make sure that there was enough wine for the restaurant. So he went to the wine cellar and tapped on the barrels to make sure there was enough wine. He then went on to study medicine, became a doctor, and used this method, the method of percussion, to examine his patients. About 50 years later, René Laennec invented the stethoscope. Laennec was not just a physician, but he also was an accomplished flautist, even built his own instrument. Back then, the method of auscultation was the direct method, meaning that the physician would put his head and ear directly on the patient's chest. The story goes that one day, Laennec was on his way to see a patient. And while he was walking to the patient, he saw kids playing on the street, and the kids played with a long, hollow stick. And one kid scratched one end of the stick, and the other one put his ear to the stick and could hear the noises through the stick. Laennec arrived at his patient's bedside, and the patient turned out to be a very large, busted young woman. And when he put his head and ear on her chest, he couldn't hear a thing. So he wondered what to do. And then he remembered the kids playing in the street, and he rolled up a piece of paper and put one end on the patient's chest and the other on his ear. And to his amazement, he could hear breath sounds better than ever. So he went home and built his first stethoscope that you can see here, which is really just a hollow stick. Shortly thereafter, the invention of the ophthalmoscope and the reflex hammer followed, and then physicians had the knowledge and the means to carefully examine their patients and then sit at the bedside to contemplate their diagnosis, as you can see here in this picture series from Sir William Osler. This painting is probably the most famous piece of art ever painted on for a physician. It's aptly called The Doctor. Was painted in 1891 by Samuel Luke Fields. Now, why is this painting so famous? Why does it speak to us so much? And experts think it's because when we are sick, like the child in the picture, we also want a physician to sit at our bedside and contemplate how to make us better. Since then, things have changed. Medical knowledge and medical technology has evolved in leaps and bounds. And now data in healthcare has surpassed data in every other sector. Of course, all this data needs to be stored and reviewed, and we're actually very lucky that we have the electronic medical record, because with just a click or 2 or 3 or 100, the data on all our patients are just at our fingertips. This study is now about 10 years old, but I think it still holds true. The researchers from Stanford actually looked at how much time medical students spent logged into the electronic medical record. And it's no surprise that on internal medicine rotation, the medical students spent a ton of time staring at the computer, more than 6 hours a day. But even on more procedural rotations, such as surgery, medical students still spend about 3 hours every day logged into the EMR. This slide looks at how much a resident's time is spent with direct patient care. And as you can see, over the last 30 years, this time has decreased significantly. Now, our residents spend only about 12 to 13% every day with direct patient care at the bedside. So we need to update the evolution of the modern physical exam to describe how physicians nowadays spend most of their time. And this picture, taken in a team room, actually describes it very well. This is what we are doing. Or if you want to adapt Luke Field's picture to 2023, it would look something like that. We are still contemplating and focusing, but we are focusing on the patient's data and not on the patient anymore. Or with Dr. Verghese's words, we are focusing on the eye patient and not the real patient. So what you might say? Medicine has evolved. We know so much more than 100 years ago. We have so many more data. All we want to know is in the computer, all the lab values, the imaging. Going to the patient's bedside, examining patients takes time and is really old-fashioned. And we don't have that time because we have to review all the data. But you might be surprised that there are consequences of not spending time at the bedside. If we don't practice physical examination and communication skills, those skills will decline, and we have actually seen a decline in physical examination skills. There's medical error associated with doing a faulty physical exam. We all hear about physician APP burnout. This is a real problem, and it's only getting worse. And last but not least, patients actually really like it when we spend time with them. They are not excited when we just look at the computer. This is my favorite Osler quote. Medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from words heard in the lecture room or read from a book. See and then reason and compare and control, but see first. This study looked at cardiac examination skills and compared different groups: medical students, residents, physicians, and cardiology fellow. It's not surprising that the cardiac examination skills improve during medical school. This is when we teach our students how to do a physical exam, when they go to the bedside, when they're observed doing this. But then after the 3rd year of medical school, cardiac examination skills really do not improve anymore. Except, of course, if you're a cardiology fellow. And then fortunately, cardiac examination skills do improve. This paper was published by Dr. Verghese and colleagues, and it looks at the consequences of physical exam mistakes. And as you can see, Consequences of physical exam mistakes are missed or delayed diagnosis, incorrect diagnosis, unnecessary treatment, delayed treatment, and unnecessary diagnostic cost. Now, I think the biggest take-home point from this paper was, though, that the major cause for error was simply that the physical exam was not even done. And this is really low-hanging fruit. We hear about burnout a lot, and as I said, it is a problem. More than half of us now are burned out. 88% of us say we are moderately to severely stressed. And more than half of us would not recommend that our kids have a career in medicine. And why is that? And one of the most striking quotes is, "I barely spend enough time with most patients, just running from one to the next. And then after work, I spend hours documenting, charting, dealing with reports. I feel like an overpaid clerk." I don't think that any of us went into medicine to be data management experts. And that's what we are doing. We are really sitting in front of a screen most of the time. So how do we get our faculty and learners back to the bedside? What can we do? And there are several strategies to reinvigorate the physical exam. We need to teach the physical exam using an evidence-based approach. There are still exam maneuvers that are taught that have no evidence and are just taught because they've been taught for decades. We need to create opportunities for intentional practice. We cannot practice the physical exam in the team room. We really need to go to the patient and examining them. We need to participate in assessment and feedback of physical exam skills. If something is assessed, it actually sends the message that it sends the message that it's important. Faculty development is really important. Our faculty is responsible for educating the residents and the students. So the faculty needs to be comfortable with physical exam skills. Point of care POCUS is really great for physical exam because you need a patient to do the POCUS on. And then last but not least, we need to value the physical exam as a way to better connect with our patients. The physical exam is not just a way to get data on your patient. It is a way to connect with the patient, to gain the patient's trust. And I'm sure many of you have the experience that a patient comes to you, is really worried about a physical concern, and you do a thorough physical exam, explain what you're doing, why you're doing it, and the patient is very reassured. Today, we are going to talk about assessment and feedback of physical exam skills. The development of expertise depends on accurate and detailed assessment and feedback. Assessment and feedback drive learning and improving. This is Miller's Pyramid of Clinical Competence. This is how we went through medical school. The base of the pyramid is the knowledge. And I remember studying long hours. I'm sure you all remember that, to get the knowledge. And this knowledge then is tested by written exams. The next step is that we have to show that we can apply the knowledge. And this is tested by clinical problem-solving cases. Afterwards, we need to demonstrate the clinical skills. And this is where standardized patients come in, the OSCEs. And the tip of the pyramid, the reason why we do all that, is actually daily patient care. How well do we do when we are with real patients? And this can only be tested by direct observation. The Cambridge model is an update to the Miller Pyramid. It takes into account that the patient and the physician don't exist in a vacuum, but there are many factors that determine if a visit is done well. There are system-related factors such as insurance coverage, patient expectations, guidelines, and then, of course, there are the individual physician-related factors such as state of mind, physical and mental health, relationship with peers. And all these factors then determine if the patient visit is done well. But again, this can only be determined and assessed with direct observation. Medical education and evaluation was changed a few decades ago to the competency-based medical education model. There are 6 core competencies: patient care, medical knowledge, system-based practice, practice-based learning and improvement, professionalism, and interpersonal and communication skills. The sub-competencies are called the milestones, and I'm sure many of you are familiar with the milestones because we have to fill out milestone evaluations on our residents on a regular basis. The nice thing about the milestones is that it's really spelled out in detail what a learner needs to do in order to be at a certain level. For example, for physical exam skills for a level 4, the learner needs to use advanced maneuvers to elicit subtle findings and integrate those subtle physical examination findings to guide diagnosis and management. If you look at the competencies and the milestones, what you also might notice is that most of these can only be assessed with direct observation. So we know that direct observation of medical trainees with actual patients by clinical supervisors is critical for teaching and assessing clinical skills. It is actually so critical that it's required by medical education accrediting bodies such as the ACGME. So how are we doing? And unfortunately, we are not doing very well. Direct observation of clinical skills is infrequent and maybe of poor quality. Fewer than 10% of residents report that they've ever been observed doing a physical exam at the bedside. So why is it so hard to teach and assess physical exam skills at the bedside? And this fishbone diagram came out of a QI project that I did a few years ago to figure out the barriers and address them. This is very busy, the slide. So this slide really distills down the most important points to challenges to teaching and assessing physical examination skills. Time is a big factor. We are really busy. And it takes time to do bedside rounding. It takes time to walk all across the hospital to find your patients. It is so much faster to just round in the team room. I'm a primary care doctor, so I'm lucky. My patients come to me. I don't have to find them in the hospital. But resident clinic is really busy, and we don't take the time to observe the residents doing physical exams. Also, observing physical examination skills is really not part of the graduate medical education culture. Once our residents graduate from medical school, we take for granted that they know what they're doing when they're doing a physical exam. And when a resident comes and says that the knee exam was normal, we don't question what was normal or if they even know how to do a knee exam. Another big point is that faculty often does not feel comfortable teaching and assessing physical examination skills, especially the faculty that went through residency during COVID. They didn't even get the chance to examine their patients anymore. And now they are asked to go to the bedside and assess and teach skills that they are not comfortable they have. That's very anxiety provoking. It is really so much safer to just give a quick prepared talk in the team room. And then last but not least, we are often not comfortable with giving or, for that matter, receiving feedback. Giving feedback is not a talent. It's not something that someone is born with. It's a skill that needs to be taught and practiced. And I don't think many of us have been taught in residency how to give feedback. And then as attendings, we are suddenly expected to give feedback and do a good job with it. As feedback givers and feedback receivers, we often forget that the goal of giving feedback is not to criticize, but to help the learner improve. We are all lifelong learners. And the skill of giving feedback and the skill of receiving feedback without feeling that our self-worth is attacked is really important. We always say that practice makes perfect, but I beg to differ. Practice actually does not make perfect. It is practice with feedback that makes perfect, especially if that feedback is given skillfully. So practice with good feedback. Feedback that is given poorly can actually be quite detrimental. The skill of giving feedback has been recognized by the ACGME, the AAMC as being so important that they actually develop milestones for feedback skills. And if you look at those milestones and you are honest with yourself, where would you put yourself? And I would love to say that I'm always a level 4, that I'm consistently engaging and challenging feedback conversation that result in desired behavior change, and that I consistently solicit specific feedback from learners that lead to behavior change. But feedback giving is hard. And I have to admit that I'm more often a level 3 or even a level 2. This is the Surgeon General's framework for well-being at work. And per the Surgeon General, there are 5 domains that determine well-being at work: protection from harm, connection and community, work-life harmony, mattering at work, and opportunity for growth. And I would argue that delivering feedback in a skillful way positively influences at least 3 of these domains. Let's take opportunity for growth. We cannot improve without feedback. So feedback that is given in a skilled way will give us the opportunity for growth. If we are working in a safe learning environment, in an environment where making mistakes is okay, and then we get feedback on those mistakes so we can get better, not only we will be protected from harm, but also our patients. And then if we get feedback that helps us improve, but that also appreciates everything that we have done, all the hard work, we feel valued. We feel that we matter at work. So how do we give feedback that makes our learners feel safe, appreciated, but helps them grow? And the methods of giving feedback have come a long way. This is the older model of giving feedback. The teacher assesses and evaluates the performance. Then the teacher provides feedback. And based on that, the learner improves their performance. This model has a lot of weaknesses. And one big weakness is that it is really focused on the teacher and not on the learner. Based on the amazing feedback that the teacher provides, the learner is expected to improve the performance. But we cannot forget that providing information is no guarantee that the learner will have understood it or valued it. Feedback is always received through feedback filters, and these are determined by the learner and not the teacher. So even as feedback givers, if we think we did an amazing job and the feedback receiver says, yes, I agree, the feedback is really not realized until the learner has done something with it. Research has shown that there are at least 3 factors that determine the quality of feedback. There are the feedback giver factors, the feedback recipient factors, and the feedback environment factors. And let's look at those factors in a little bit more detail. Let's start with the feedback recipient factors. If the feedback receiver does not think that the feedback provider has any credibility, that they don't know what they're talking about, they will completely dismiss the feedback. Constructive feedback is often seen as a personal attack. And I'm sure we have all had the experience that if someone walks up to us and says, "May I give you some feedback?" we immediately feel uncomfortable. We immediately want to defend ourselves instead of taking a step back, listening to the feedback, and thinking of how it can help us grow. Personality, temperament, emotions in the feedback receiver all play a big role on how the feedback receiver takes the feedback. Goal orientation. Is the feedback receiver more performance or more learning oriented? And then if the feedback receiver is preoccupied with something else, they will not even listen to the feedback that you have. The feedback environment plays a big role. It's very important to have a safe feedback environment, and lack of time is detrimental to quality feedback. If we are stressed, if we're in a hurry, the quality of the feedback will suffer. Medicine is a culture that does not support making mistakes. So instead of admitting to having made a mistake or admitting that we don't know something, we stay silent because we are worried that we are going to get punitive feedback. As I said before, unfortunately, our culture does not support direct observation, and feedback conversations are still often one-way conversation from the teacher to the learner instead of being a dialogue. And then the feedback giver factors. I cannot mention that often enough. No direct observation of the learner. There is a lack of training in how to give feedback. Again, feedback skills are taught, learned, and need to be practiced. One way of practicing feedback skills is really reflect after a difficult feedback conversation. I know we're often really happy when it's done and just want to go on with our day, instead of taking a minute or two to reflect how this feedback conversation went and how it can be better next time. Our feedback is often way too general. We say, "Good job," or "Learner needs to be more efficient, learner needs to read more," but what does that actually mean to the learner? How does that help them? We like our learners, so we don't want to hurt their feelings. We don't want to hurt our relationship with them. So our feedback is often way too positive. We also worried about retributions. If we give constructive feedback to a learner and they take it the wrong way, they might turn around and write us a bad teaching evaluation. And then that's on our file and we might not be promoted. Our emotions play a big role on the quality of the feedback we give. And then we are all very busy, and filling out evaluations on our learners is often not the top of the priority list, so we delayed for weeks or months. And by then, we might have completely forgotten how the learner performed. As you can see, there are lots of factors that determine the quality of feedback, and many of these factors we are not even aware of. So here are some tips for giving effective feedback. The one thing we cannot forget as medical educators is that we give feedback to our learners to help them turn out to be amazing physicians who give the most outstanding care to their patients. So we always have to frame the feedback in the context of growth, whether we are giving it or receiving it. The first step of giving feedback is to ask permission to give feedback. You don't know what's going on with your learner that day, so ask permission. And my learners are always very polite and nice, so I never had a learner who said, "No, you cannot give me feedback." But even if they say yes, look at the tone of voice, look at the body language. And if that tells you, "No, not today," hold the feedback for a different day, unless, of course, it's a safety issue. Always base your feedback on direct observation and be very specific. Try not to ask why questions. A why question immediately puts the feedback receiver in the defensive. Why did you do that? not a good question to ask. Instead of ask, I'm curious, help me understand. Feedback needs to be about the performance and not about the person. It always needs to be objective. And then, very important, feedback should always include actionable information. We want to grow from our feedback. The good news is that giving feedback at the bedside is much easier than giving milestone or end of rotation feedback. For giving feedback at the bedside, you can actually use the older model, but you have to make sure that you create a safe learning environment. So prior to the observation, the teacher needs to ask the learner what they want to work on. This will normalize it as a learning environment. Then the teacher observes, assesses, and evaluates the performance. Then the teacher asks the learner for self-assessment. How do you think you did? And then asks the learner for permission to give feedback. After that, the teacher provides specific feedback and always reinforcing and constructive. And always start with the reinforcing feedback because that makes the learner feel safe and it shows that they are much more receptive for constructive feedback. Also, if you have seen 10 things that you would think the learner needs to improve, don't mention all those 10 things. Focus on 1 or 2. Then the teacher asked for the learner's understanding of the feedback and a follow-up plan, and hopefully the learner improves their performance. This is the ask, tell, ask model. So again, the teacher asks the learner for self-assessment. Then the teacher tells the learner reinforcing feedback and corrective feedback. And then the teacher asks the learner for the understanding of the feedback and a follow-up plan. Now, what models do we have nowadays to evaluate physical examination skills? There's PACES, the practical assessment of clinical examination skills, APEX, the assessment of physical exam and communication skills, and the mini CEX, the mini clinical evaluation exercise. PACES is done in the UK system. It's a high stakes summative assessment of clinical examination skills. At the end of residency, the UK learners need to pass PACES in order to go on to their specialty training. PACES has 5 stations, and the learners find real patients with real physical findings or standardized patients in those stations. And the learners are observed by 2 faculty members. They don't get their result right afterwards. There's really no feedback, just a grade. So it's purely summative. APEX is based on PACES, but it is purely formative. Currently, APEX is done at Hopkins and at UAB, the University of Alabama in Birmingham. Again, it is based on PACES, so the learners go through stations where they encounter real patients with real physical findings or standardized patients. They're also observed by 2 faculty members. But compared to PACES, it's formative. So the learner gets immediate feedback on their physical examination skills after every station. APEX and PACES are an amazing way to assess physical exam skills, but as you can imagine, require an enormous logistical effort. They are not done during the clinic day. They're done in a skills center. The patients have to be there. So it requires a lot of work, and most academic centers just don't have the resources to do this. The mini CEX was developed to do an observation evaluation that can be integrated in the clinic day. And I'm sure you are all familiar with that because in clinic, for example, we have to fill out a mini CX on every resident twice a year. Otherwise, they cannot graduate. The mini clinical evaluation exercise assesses or can assess medical interviewing, physical examination, professionalism, clinical judgment, counseling, and efficiency. And those then are rated on a 9-point Likert scale. It is a 10 to 15-minute witnessed real patient encounter. And then there's 5 to 10 minutes of feedback. So the mini CX is amazing because residents can be assessed in various clinical settings with a diverse set of patient problems based on real observation. However, how does it perform for physical exam? And unfortunately, it doesn't perform that well. The assessment of the physical exam is one of the least frequently performed assessment, and residents received the lowest ratings in the physical examination when it was assessed. So there's a gap. We need to have a way to assess physical exam skills that really focuses on the physical exam, such as APEX, but that is feasible, can be done at the bedside, and can be embedded in the clinical day. And seeing that gap, the Society of Bedside Medicine developed the 10-minute moment. We published that last year. Here's the paper. Now, what is a 10-minute moment? The 10-minute moment is a problem-focused physical exam. We call it a 10-minute moment because it does not need to take more than 10 minutes to give feedback at the bedside. Of course, you can take an hour to give feedback, or you can take one component of the 10-minute moment and make it a 1-minute moment. We all know that history-taking skills are really important. The history determines the way of the workup. But the 10-minute moment is not about history-taking skills. It is only focused on physical examination skills. We understand that many faculty are not comfortable with all physical exam maneuvers. So every 10-minute moment actually has an integrated faculty development piece. Those are pearls that the faculty can read, remember, and then teach back to their learners. And then it has a learner assessment. This is a list. This list was created based on expert consensus and thorough literature review with exam maneuvers that we would expect a resident to do for a good physical exam for a specific physical problem. Then there is a yes/no column, and then we also added areas for feedback. These are areas that we have noticed our residents often struggle with. For example, examining something with the clothes still on and not exposing the area of concern. So how do I use it in clinic? How do we use it in the ambulatory setting? And the way we do that is that the learner or the attending identify a suitable patient with a 10-minute moment problem and then talk about the learner's goal. The learner then talks to the patient to get a detailed history, but does not do a physical exam. The learner then meets with the attending and summarizes the patient's history for them. And then the learner and the attending go in the room together, and the attending witnesses the learner's physical exam. Afterwards, the attending does their own exam to show technique, verify and identify abnormalities. And then the learner and attending finish the patient visit together. The patient leaves and the attending gives immediate feedback to the learner. And I'm doing the 10-minute moment in clinic now quite frequently, and my residents really like it. Currently, we have 8 10-minute moments: dizziness, back pain, knee pain, shoulder pain, heart murmur, heart failure, abdominal pain, jaundice. We picked those because these are common in and outpatient problems, and we are in the process of making more. And we also made videos of all of these 10-minute moments so the learner or attending can watch a good physical exam for these problems. And these videos are available on YouTube or on our website, the Society of Bedside Medicine. Thank you. And I put my contact information there. So if you have an idea of a 10-minute moment and you want to collaborate, please contact me. Thank you very much.
Dr. Artandi, thank you for that. I have gotten various comments saying how quote unquote astounding this is. Dr. Golden, thank you for that comment as well recently. I have questions. I don't know if I'll have time to get to because we already have questions from the audience. So I'll prioritize those, of course. But thank you and really emphasizing a topic that I think all of us clinicians understand and we don't talk about enough. And thank you for sharing some great strategies around it. I'll start with Dr. Golden. Actually, had a comment here. Do you think that rounding with learners in primary care in clinic before they see patients can be helpful? So you talked a little bit about that, but the strategy of how you organize, how you do rounding.
So in primary care, the patients come based on the schedule. So pre-rounding might be a little bit hard. So I don't know how I could do that logistically with my learners. I think the way we do it right now, if I don't do the 10-minute moment, is that the learner goes in, talks to the patient, and comes back, presents the patient, and we go in together. And that works really well. Except that, again, we don't observe physical exam skills. So that's why we integrated the 10-minute moment.
Excellent. Thank you. I have a question here. Talking a lot about video visits and how it's perhaps changed. I know, again, I mentioned briefly in the introduction, when COVID first started, you were key in creating a video to help people to figure out how to do the exam
Yes.
at that time. This question is about that. How have physical exam skills changed with the advent of increasing virtual and video visits? Like how you've definitely been in the middle of this. How's that? Do you think it's changed dramatically for the future or where we are now with that?
So video visits are here to stay and they're really helpful. I mean, patients don't have to take the time to take off from work, get childcare, so they're great. And when I started out with the video visits, I did not think a physical exam could be done, but I'm surprised at how well some physical exam maneuvers can actually be done in a video visit. Video visits are also great to introduce the patient's environment. We often don't see the patient's home, so that's wonderful. And then, sure, some of the things cannot be done, are not adequate for a video visit. But for example, MSK, I can do a good shoulder exam and a knee exam, back exam on a video visit with the patient's help. So I walk them through what they need to do, and the patient actually really like it and are very engaged.
Excellent. This is an interesting question. I saw some earlier, I was thinking about it a lot. Thank you for voicing so clearly the challenges with feedback. Any tips on how you make the learner comfortable about giving the supervisor feedback as well? Bilateral communication can be so helpful in parties growth. Yeah, that's interesting one. I don't typically, understandably get feedback a lot, at least in person. We have online stuff, but actual on the spot feedback. Any thoughts on that?
That's actually a really great question. I'm sure we as attendings are not comfortable asking the resident, hey, how did I do? And then the residents also don't want to hurt our feelings, so they might not tell the truth. And it's all about the relationship. I think if we tell the resident, hey, I'm trying to be better at this, can you help me? And then really listen to the feedback instead of getting all defensive. That's the first step.
Okay, great. Next question. So a lot of great questions, by the way, are popping up here. And after this next question, I'm going to go to Dr. Skeff, who's on us with video. Dr. Parsonet is asking, do you see us integrating ultrasound into the PE, the new stethoscope? As you know, there's new digital stethoscopes, but of course, there's the ultrasound, which we call, in a way, our new stethoscope too. What's your thoughts on that? Are you using it a lot in clinic?
In the outpatient setting, not. We're just starting. I'm a big fan of ultrasound because, again, it gets us back to the bedside and it can be super helpful. I don't think it will replace physical examination because it just doesn't. It's important to first examine your patient and then do the ultrasound, but not substitute the ultrasound. So yeah, but I definitely think it complements the physical exam.
Yeah, I think that makes a lot of sense. We've had a lot of our own faculty in the bed med groups talk about it. It's an extension of the exam. kind of what you're saying. That's wonderful. I'm really excited we have Dr. Kelly Skeff with us on the panelist side today. It's such an honor to have him with us. Dr. Skeff, are you there? And can you hop on your video and please, any comments or questions, be very, very welcome.
Oh, there we go. Hello there, everybody.
Hey.
What a treat to listen to you, Maja. I first want to begin by just saying that this was a wonderful discussion, a wonderful talk. And the most important thing I would like to highlight for you is that you dealt with feedback, highlighting the complexities of the process. It is such a complex process, and you were comprehensive and let us realize the number of different things that we have to consider. And so the only piece I would say, and I know you would want me to say this, the only piece I would say that I would, the word that I would let people know that I would be a little concerned about is the word always. Once in a while, we do have algorithms for doing things. And as you suggested, that one always gives positive feedback before negative, or one always. If you have highlighted so nicely, you have created a learning climate where people are ready to receive the feedback, then the always may not be necessary. And in fact, one may be able to go right at an issue that somebody can change because of the fact that they recognize the caring that you have and the commitment to a positive climate. If the learner knows that we care about them so deeply, and if the learner knows that everything is in their best interest, then the capability of us going in different directions at different times becomes greater. But I just want to congratulate you. This was a wonderful, learned, and well-organized and incredibly comprehensive talk, and I'm proud to listen to you.
Thank you. And thank you so much for making this point. I could not agree more. So thank you.
Thank you, Dr. Skeff. It's so great to have you with us on the panel side today. I want to also, there's a few more questions here I want to make sure we get to. Do you think that e-consults, when exam findings typically alter differential diagnosis, should be restricted to arising from in-person visits? Another kind of question about the in-person versus video. So do you think that we should really be more in-person when we're using the exam to make very important decisions and diagnoses?
I love e-consults, I have to say. I mean, I work express care, and especially DoM e-consults are great, really wonderful. And I don't need an in-person visit for that. What I often do is I have the patient take pictures of their rash. I get a good history. And then if I don't know what it is, I do the DE consult. And it's very, very helpful. And I always learn a lot.
Excellent. Yeah, that's a good point. It varies a lot depending on what the exam issue is. Another question here, is there a plan to incorporate the 10-minute moment into a mini CEX style written feedback style? At this time, I believe residents are still required to have mini CEX completed. So is there it's an interesting question to integrate it into things that they're already doing?
Not yet. Again, the mini CEX is something that's mandatory that we have to do on our residents. The 10-minute moment is formative, voluntary. I would love it if it turns out then that we do a more mini CXs on physical exam skills. So that would be great.
Can you talk a little bit more? Dr. Benitez has a question here about just in general, the impact on the physical exam. Can you tell, since the pandemic and that we moved so much, can you just give us your experience of how it's impacted? You mentioned it's here to stay and we're going to have video visits and so on, but how has it, in your opinion, how's the pandemic affected our ability to teach and learn the physical exam?
Oh, the pandemic was terrible for that, right? I mean, we cannot do a good physical exam when we're all in PPE. So, and I think that I noticed that residents and medical students are just not as comfortable anymore because they did not get the chance to practice this. We didn't have standardized patients. So all these skills, hands-on physical exam, really have decreased through the pandemic. So we have to make a big effort to get those skills back.
Dr. Artandi, I want to ask you a question. I think about this a lot, both as a clinician, but also someone who's been teaching exam with you for so many years. The practical aspects of how medicine's changed. You talked about this a lot. I find that as an inpatient doc hospitalist, we grew a new hospital this year and we're so more spread out. And I'm teaching less physical exam because of that, such a practical thing. If all our patients we'd probably be seeing every patient together, could it be so quick? But when we're stuck, I'm forcing the residents to walk with me. It takes them away. I could see them die a little bit when they're forced to stand in the hallway waiting for the other intern to present while they have a million things to do and they're stressing out. And so I don't take them to the bedside as much anymore. But I do when the residents down the hall, there's a good teaching exam. So the practicality. Can you comment more about that, particularly in the clinic, has both also you inpatient medicine as well, but has your thoughts, particularly on the outpatient too, how's that practicality also changed in clinic where it's just things have been changed and it's just harder to do so for various reasons?
Yeah, and as I said before, the culture really does not make us attending go in and observe the physical exam. And for several reasons. And it's so important because physical exam is fun. It is really fun to look at the patient and figure out all these little things. You can learn a lot about a patient just by being curious and looking at it. And that, for me, gives me the joy of medicine. I don't really like reviewing data on the computer. I like talking to my patient, examining my patients. And I think we have to prioritize that.
One of my favorite things you said just now is you gave advice on giving advice. And one of those aspects you did that was framing it, asking the learner what they want to learn. Because I do feel comfortable sometimes if I realize something and I'm like, oh, I got to give feedback. And I'm trying to make sure they're comfortable first. But if I had started that rotation off by saying, hey, what do you want to learn? And now I'm following up on that. That's a bit of a wow, that's super powerful. Any other thoughts about how you use that both in the inpatient or outpatient setting? Do you think that you start at the start of rotation or start of a clinic? How do you practically implement that?
Yeah, my learners know now that I'm very focused on physical exams. So anybody who comes with a cool finding, they find me, which is very cool. And I think just modeling the excitement about physical exam, how fun it is, and then showing the residents. And eventually they will get into it and they will say, hey, I want to learn the shoulder exam or the knee exam, or talk to me about rashes. And then we go from there.
That's wonderful. You talked earlier about how we have assessment drives learning. If people have a test on something, they'll try to learn it better. But
yeah,
we also mentioned how if you are showing your enthusiasm and and the learners know that you're someone who cares about something, that'll also drive culture too.
you have to model that.
So, well, thank you. As we're just about to hit 9 o'clock, thank you for helping be a big mover in this field of trying to create more people like yourselves. Thank you so much for joining us today. And thank you for everybody for sticking with us. I hope everybody has a great rest of the day and week, and we'll see you next week. Thanks again, Dr. Artandi.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.